You don't need any introduction,
sir. Thank you, thank you. I was about to say that there is no introduction needed. Sir, respected Dr. Arulraj sir, Dr. Hariran sir, Dr. Ravishankar sir, and also the Dr. Pitchmani and also the organizers of this great conference. I thank you for this wonderful opportunity to give the audience something about the basics of electrocardiogram. So although I do this 4 lectures in 4 hours, I have to do this lectures 2 hours. So just let me go through this very important slide so that you will have some sort of great idea about the basics, and then of course you can learn better in detail. So basically, we call this workshop as ECG Ignited. So it's a basic ECG learning series, and we have been doing these workshops for through the ECG and Echo Club of Trichy. And ECG is always surrounded by mystery, as you can see that here. So because as an undergraduate, if you ask ECG, your assistant professor will say, you are an undergraduate, you need not have an ECG knowledge. Then you enter postgraduate and ask for the ECG, and the same assistant professor will ask you, without knowing ECG, you have come to postgraduate, is it? So that sort of dialogues we have been hearing for many years, and it is always surrounded by mystery. So because it is a complex topic, people believe it is a complex topic, and we try to make it easy. So what we are going to see is the basic learning, and basic learning of ECG has got 4 lectures. In the first lecture, we are going to see the conduction system of the heart, depolarization and repolarization. And second lecture, we'll be seeing about the leads. And the third lecture, we'll see about how to measure each one of the waves and their abnormalities. And the fourth lecture is going to learn about the electrical axis of the heart. So first, we have to pay tribute to this man, William Enthoven, who got the human ECG in 1903 and got the Nobel Prize in 1924. And you can see that 1903 ECG is not much different from our own ECG today. So the same PQRST. And people wondered why William Enthoven started with the P. So it is customary to start with A or X, Y, Z, and so on. So William Enthoven wanted to be different, and he wanted to start with O. He did not want to start with 0. So he selected the next sector as the PQRST. So that goes on for decades. So first of all, what is electrocardiogram? Electrocardiogram is the investigation which gives you the electrical properties of the heart. Heart as a pump has got 2 properties, electrical and mechanical. So ECG tells you where this electricity to the heart is produced, how much it is produced, and what frequency with which it is produced, and what pathway it is traveling, what speed with which it is traveling, whether it is reaching the appropriate place at the right time, and the appropriate place is responding to this current correctly. So this is the information you get from electrocardiogram. Whereas when you do echocardiogram, it gives you the mechanical properties of the heart. It tells you how the heart is contracting and relaxing, what are the cardiac chambers, dimensions, and how the valves are working, whether they are closing properly and they are opening properly. All these mechanical properties are shown by echocardiogram. That's why to say the heart is normal, you have to do both. That you have to learn electrical properties through electrocardiogram, and you have to learn the mechanical properties through the echocardiogram. And please remember, like any other investigation, don't ever come to a diagnosis, conclusion, and also the planning of a management with ECG alone. Always you must have clinical details of the patients before you interpret electrocardiogram and plan a management. So now we have a modern ECG machines which can give you the electrocardiogram just in 2 seconds. They not only give the electrocardiogram within 2 seconds, they also give you a diagnosis within 2 seconds. Then you may wonder why I should sit in this afternoon where my best choice will be the sleep and listen for the ECG for 2 hours if my machine is going to give me the diagnosis. So this is a 16-year-old fellow, and he has got some T-wave changes here, and the electrocardiographic machine computer is calling this an acute myocardial infarction. Imagine the consequences that if you thrombolize this patient or give anticoagulants to this patient with a T-wave change of 16 years. That's why it is very, very important to have your basic ECG knowledge to interpret electrocardiogram rather than the electrocardiographic diagnosis given by the ECG computer. So believe the computer in you rather than the computer in the machine. So that's why if at all you are, after this workshop, still you are interested in electrocardiogram and you wanted to buy a ECG machine, always buy an ECG machine with this measurement software only and not the interpretation software, because many times it may mislead you. So first we look at the depolarization. First we look at the conduction system of the heart before we look at the depolarization and repolarization. The conduction system of the heart includes the primary pacemaker of the heart. So all the electrical impulses for the normal heart is produced by this primary pacemaker of the heart, which is called the sinoatrial node, which is situated between the junction of the superior vena cava to the right atrium. This is called the primary pacemaker of the heart because in the normal heart, no other area in the heart can produce more fastest spontaneous impulses better than the sinus node. So sinus node can produce the fastest and also the spontaneous impulses. That's why it becomes a primary pacemaker of the heart. It can produce 60 to 100 per minute spontaneously. That's why it's called primary pacemaker of the heart. Then we have two secondary pacemakers of the heart. One is the atrioventricular junction. The atrioventricular junction is also able to produce spontaneous impulses, but the number of impulses it can produce is much less than the sinus node. And another secondary pacemaker of the heart is the ventricle. The ventricle muscle itself can produce the spontaneous impulses, but it can produce only 40 per minute. So because the fastest spontaneous impulses, the primary pacemaker is sinus node. Whenever the sinus node fails, these two secondary pacemakers may take over so that they do not allow the heart to go in for an asystole. It is like a UPS, when the current goes off, the UPS takes over. So whenever the primary pacemaker fails to produce adequate impulses, or the impulses of the primary pacemaker is not able to reach the ventricle, then of course the secondary pacemakers take over, and so that the heart is not allowed to go in for a asystole. So when you look at the conduction system of the heart, once the sinus node produces the impulse travels to the next junction, which is called the atrioventricular node, through pathways. One is through the internodal pathways, the three internodal pathways, and also through the atrium. By depolarizing the atrium or conducting through the atrial muscle, the impulse getting conducted through the atrial muscle, it can reach the AV node. So the atrioventricular node, the impulse is coming from the sinus node by three internodal pathways as well as through the atrial muscle itself. So the atrioventricular node is called the speed breaker of the heart, because the atrioventricular node is not going to conduct the impulse at the same speed as it receives. It is going to delay the impulse. So why it is going to delay the impulse is that, for example, if you see that the right atrial, the atrial contraction, the ventricle contraction, if the impulse is going very fast to the ventricle, the atrium will not be finishing its contraction before the ventricle starts contracting. So by delaying the impulse, it allows the time for the atrium to complete its contraction, emptying all its blood to the ventricle so that the end diastolic fiber length of the ventricle is adequately expanded so that to have a good stroke volume as per Starling's law. That's why the AV node delays the impulse to allow the atrium to complete its contraction. Then the impulse goes through the conduction system of the heart to reach the ventricle. So after leaving the atrioventricular node, which is the speed breaker of the heart, the impulse rapidly spreads through the bundle of His and then divides into right bundle branch and the left bundle branch. And the left bundle branch divides into left anterior vesicle and also the left posterior vesicle. Because left ventricle having a larger muscle mass, it has got two wires and also two arteries. The two wires are left anterior vesicle and left posterior vesicle, and the two arteries are left anterior descending artery and circumflex artery. After this vesicular branching, there are very, very small tweaks of this conduction system, which are called the Purkinje fibers of the heart. So the bundle of His right bundle branch, the left bundle branch, and also the vesicles and Purkinje fibers are collectively called as specialized conduction system of the heart, because they can conduct the impulse at a very rapid speed. And because of that, the entire trillions of ventricular muscle cells can be depolarized at a very short span of time of 0.08 seconds, because the ability of the specialist conduction of the heart to transmit the impulse to the ventricular muscle at a very rapid speed. So now we can look at the entire ventricle and also the atrium to see the conduction velocities across each one of these regions. For example, when you look at the atrial muscle and also the ventricular muscle, when you look at the atrial muscle and also the ventricular muscle, they conduct at the speed of 0.5 meters per second. Whereas when you look at the AV node, I told you speed breaker, the impulse is going very, very slowly. It is conducting at the speed of 0.05 meters per second. Whereas look at the specialized conduction system, which is bundle of his right bundle, left bundle, and also the Purkinje fibers and also the vesicles. You can see that they are conducting at the speed of 4 meters per second, almost 10 times that of muscle and 100 times that of atrioventricular node. That's why the ventricular depolarization is so rapid and your QRS is so narrow, because the impulse is conducted rapidly through the specialized conduction system of the heart. Now we can also know how much time it takes for my sinus impulse to ultimately to reach my ventricular muscle. So it takes 30 milliseconds from the sinus node to the AV node through the internodal pathways as well as through the atrial muscle. And the atrioventricular node gives the transmitting time, transit time at the AV node is going to be 130 milliseconds because that impulse is going slowly there. Then, of course, through the rapidly spreading through the specialized conduction system of the heart, it takes only another 30 milliseconds for the impulse, once it is released by the AV node, ultimately to reach the ventricular muscle cell through this specialized conduction system and through the Purkinje fibers. So when you look at the entire time, the addition of the entire time from the sinus node to the ventricular muscle, it is almost 190 to 200 milliseconds. So this is called atrioventricular conduction time. So the atrioventricular conduction time is 190 or 200 milliseconds. And this atrioventricular conduction time roughly represents the PR interval we see in electrocardiogram. So the PR interval tells us what is the time taken for my sinus node impulse to ultimately reach my ventricular muscle cell. So this is the conduction velocities across each one of the region of the heart, and it is the time taken for the sinus impulse ultimately to reach the ventricular muscle. So once the impulse reaches the ventricular muscle, the muscle responds to this current, which is called the depolarization, and then it recovers from the impulse, which is called repolarization. So the repolarization are very big terms, and basically why the ECG is complex is because it is primarily based on physics. We are all doctors because we did not like physics and maths. So that's why, because it is difficult to understand, because many physical principles are involved in the ECG recording and ECG learning. So to understand the depolarization and depolarization, I want you to imagine each one of your cardiac muscle cell as a battery cell. The battery cell has got the polarity in the superior region and the polarity in the inferior region as plus and minus. In the cardiac muscle cell, you have to imagine the polarity outside the heart and inside the heart. So in a normal resting cell, which is called the polarized state is nothing but the cell is not received the current yet. So at the resting state or the polarized state, the outside cell is positive, inside cell is negative. Why outside cell is positive is because of the maximum concentration of positively charged ions outside. That's why the outside cell is positive and inside cell is negative. So this is the resting state. Once the current comes and stimulates a cardiac muscle cell, what it does is it is going to change the permeability of the cell membrane, and it is going to open the channels for certain ions, especially positive charge ions. So now, because the cell is permeable and the channels are open, there's a rapid rush of passively charged ions inside the cell to make inside cell positive and outside cell negative, which is called the depolarization. So depolarization is opposite of polarization, where inside cell is positive and outside cell is negative. If the cell is in the same state, the next sinus impulse will not be able to stimulate this cell. So what the cell has to do is to come back to the original state of the polarization. So for that, what it has to do is it has to actually eliminate positively charged ions from inside the cell to outside the cell. So the main positive charge ion which goes out to make or to get the intracellular negativity is the potassium ion. So the potassium ion goes out, and also the sodium and calcium which have come in during the depolarization also go through the various channels. But the main ion which goes out during this repolarization process is potassium ion. So once the potassium ion goes out and the positive charge ions are going out the cell, once again outside cell becomes positive, inside cell becomes negative, which is called the repolarization. So this goes on for every impulse which is received by cardiac muscle cell. be it an atrial muscle cell or a ventricle muscle cell, and the wave of depolarization is transmitted. So one cell gets depolarized, repolarized, then it goes to the next cell to get depolarized and repolarized. So the wave of depolarization is built, and also the entire heart is depolarized through this transmission of the impulses from one cell to the other. So this is the basically depolarization, repolarization. And if you can see it in a better diagram, so what happens in depolarization is my positive charge ions are entering the cell, making the inside cell positive, outside cell negative. And during repolarization, my positive charge ion, especially potassium, is leaving the cell and making the outside cell positive again and inside cell negative again. So what is the ECG is nothing about the learning about the depolarization and repolarization of each one of your cardiac muscle cells through the waveform of PQRST. What we see as a PQRST is nothing but the depolarization and the repolarization of the various cardiac surfaces and various cardiac tissue. So that is about what is happening at the cellular process is this, and what this is seen as the electrocardiogram. So now we can assume and say how we get this electrocardiogram pattern, our ECG paper. So now we can take up a strip of ventricular muscle cells. So this is a ventricular muscle cell. This is a strip of ventricular muscle cells. So as I told you, the first we see the depolarization going from the endocardium to epicardium, making outside negative. So then the repolarization happens from endocardium to epicardium, which is making once again outside positive. So when you look at the depolarization, it can produce a wave which is called the QRS complex, which is the ventricular depolarization. And also the wave which is produced by the ventricular repolarization is the T wave. So here the depolarization is producing a positive wave and the ventricular repolarization is producing a negative wave. So normally, if you look at the electrocardiogram, the depolarization should be opposite to repolarization, which means in a ventricular QRS complex and T wave, you expect the T wave to be positive. You expect the QRS to be positive and T wave to be opposite to the QRS complex in a normal situation, because the depolarization and repolarization, when they start from the endocardium to epicardium, because they are opposite electrical processes, you likely to have the depolarization as a positive wave and the repolarization as a negative wave. But when you look at the normal electrocardiogram, it doesn't happen, because always the T wave goes with the direction of the QRS complex. Whenever the T wave is opposite to the QRS, you think it is abnormal. It can be ischemia, it can be digoxin, or it can be hypertrophy. So many conditions will produce the T wave opposite to the QRS. But logically, what should happen should be the T wave should be opposite to the QRS. But why the T wave is in the same direction of the QRS? Now look at the depolarization, which is going from the endocardium to epicardium. Now look at the repolarization. It happens from epicardium to endocardium. So two opposite processes occurring in opposite directions. That's why whenever your QRS is upright, the T wave is upright. So the depolarization. So one principle you have to remember for your life is depolarization is happening from endocardium to epicardium. As you can see it from the endocardium to epicardium, and the repolarization, which is producing the QRS complex, which is positive. Epicardium is the starting point of repolarization. From epicardium to endocardium is repolarization. Two opposite processes are occurring in opposite directions. That's why it makes positive T wave. So now we can understand in a particular electrocardiogram, whenever I see the QRS is upright and the T wave is negative, what I have to assume is this. What I have to assume is my depolarization and repolarization are happening in the same direction. So whenever the T wave is opposite to the QRS, the repolarization direction is changed. The etiology of the directional change may be ischemia, digoxin, ventricular hypertrophy, and so on. But the principle you have to understand is the T wave will be opposite to the QRS only when the depolarization and repolarization are going to happen in the same direction, but they have to happen in the opposite direction. Now we can derive how we are going to see the depolarization and repolarization and also the various waves in the electrocardiogram and correlate them to what is happening at the cellular level. So you cannot see the sinus node activity in the electrocardiogram. The first activity you see is the P wave. P wave is due to atrial depolarization. Here the depolarization is given as the orange, and also the repolarization is given as pink. So now as the depolarization, we can assume that the sinus node is producing this P wave by looking at the direction of the P wave. by looking at the configuration of the P wave. So we don't see the sinus node activity on the electrocardiogram. If the P wave is in a particular direction and it is a particular configuration, we assume this P wave is produced by a sinus node and we call it as a sinus rhythm. So the P wave is due to atrial depolarization, biatrial depolarization. Then the impulse comes to the atrioventricular node. So you can see that here the ECG is full of straight lines and also the waves. So whenever there is a wave, there is ionic movement in the cardiac myocyte. That means either the positive charge ion is going inside the cell or it is coming out of the cell. When that happens, it is a wave. No ionic movement is happening, it is a line. So we have 3 waves and 3 lines. The first line we are going to see is the PR segment. So as the impulse has come to the AV node, now the AV node is going to delay the impulse because it is only delay the impulse. There is no ionic movement here. So this is a straight line, which is a PR segment, which is the atrioventricular nodal delay. Then the impulse rapidly spreads through the specialized conduction system of the heart and depolarizes my entire ventricular muscle cells, and it is shown as QRS complex. So the QRS complex is ventricular depolarization. After the ventricular depolarization, there is a small gap between the depolarization and the repolarization, which is so now here you can see my entire ventricle is depolarized. The repolarization has not started. That gap between the depolarization and repolarization is called ST segment. Once again, it is a straight line because no ionic movement is happening because repolarization has not started. Now the repolarization starts from epicardium to endocardium to make the T wave, and because the direction of the depolarization and the repolarization are opposite, the T wave goes with the direction of the QRS complex. So the T wave represents ventricular repolarization. After the ventricular repolarization, the entire ventricles are repolarized. Now it is time for the sinus node impulse to produce next impulse and produce a P wave. So the gap between the end of repolarization and the beginning of the next atrial depolarization is called the TP segment. Once again, it is a line because there is no ionic movements are happening here. So the 2 waves we don't see here are, one, I told you about the sinus node activity we don't see. Now I told you about the atrial depolarization. We don't see atrial repolarization. The atrial repolarization is inside the QRS complex. That's why you don't see atrial repolarization. So these are the 2 things we don't see, whereas all the other activities we see through the PQRST. When you look at this animation, it can beautifully tells you the P wave is due to atrial depolarization. PR segment is ADV nodal delay, and QRS complex is ventricular depolarization. The ST is the gap, and the T wave is due to ventricular repolarization. So the ECG is nothing but 3 waves and 3 lines. The 3 waves are P wave, atrial depolarization, and the another wave is ventricular depolarization as the QRS complex, and another wave is the T wave, which is the ventricular repolarization. 3 lines are the PR segment, which is AV nodal delay, and the ST segment, which is the gap, and the TP segment, which is the end of repolarization before the next atrial depolarization. So ECG is very simple, 3 waves, 3 lines. And of course, we can also correlate our action potential to our electrocardiogram. So this is what actually happening inside the ventricular or the cardiac myocyte. So you can see now we can understand this number, which is minus. So this is inside the cell. So inside the cell in a resting state, it is minus. So that means it is a resting state. Now, when the impulse comes and stimulates the cardiac myocyte, there is an opening for the positively charged ions. The sodium ion rapidly enters the cell to make inside cell positive, which is called the ventricular depolarization. After that, the positivity is maintained by another entry of calcium and positive charge ion, which is calcium, which maintains the positivity. Then originally the intracellular polarity has to come negative by the exit of the potassium charge ions. So during repolarization or in the downslope of the ventricular action potential, the atrial action potential, the potassium leaves the cell, which makes the intracellular negativity again. So when you correlate these activities of the action potential to the electrocardiogram, the upstroke of the action potential where the sodium entry is represented by the QRS complex, the plateau of the action potential where the calcium enters is shown by the ST segment, and the exit or the outpouring of the potassium is shown by the T wave. So The sodium represents the QRS complex, and the calcium is represented by the ST segment, and the potassium is the T wave. That's why whenever you have a sodium channel abnormalities, like sodium channel blockers, it will affect the QRS complex. Whenever you have a hypocalcemia or hypercalcemia, the ST segment is affected. Whenever you have hyperkalemia or hypokalemia, your T wave gets affected. Now you have understood the electrocardiogram and the electrolytes. So now when you look at electrocardiogram, not as if all the waves are positive or negatives. Certain waves are positive, certain waves are negative in particular leads. So you have 12 leads. So every lead is not going to show a positive wave or a negative wave. So something are positive, something are negative, something are almost positive or negative. Why this is happening? So whenever an impulse is coming or the wave of depolarization is coming towards a lead, that lead will record a positive complex. If the atrial depolarization is going to come towards a lead, the P wave has to be positive. If the ventricular depolarization is coming towards a lead, that this ventricular QRS is going to be positive. If a wave of depolarization or this going to go away from a lead, that lead will show a negative complex. If my atrial depolarization is going to go away from a lead, that lead will show a negative P wave. If the ventricular depolarization is going to go away from a lead, that lead will show a negative QRS complex. Whereas instead of towards or negative, if the impulse is going exactly perpendicular to a particular lead, that lead will show equal positive and negative QRS complex, which is shown as the equiphasic complex. So the lead can be positive wave, or the lead may show a negative wave, or the lead can be showing a equiphasic wave, depends upon whether the impulse is coming towards the lead or going away from a lead, or it is going to be perpendicular. Now you have to understand another term which is called the vector. So the vector is nothing but, although the sinus node impulse has to depolarize all the areas of the heart, the atrial and the ventricular, all the surfaces, anterior, posterior, lateral, medial, right, left, and so on. Ultimately, what happens is, depending upon where you have the maximal muscle mass, the net cardiac impulse will be traveling, net cardiac impulse or the net electrical impulse of the heart will be traveling towards the site where I have the maximal muscle mass. In a normal heart, the left ventricle has the largest muscle mass, which is left and inferior. Whereas my electrical activity for the heart is starting in the sinus node, which is right and superior. So my net cardiac impulse is likely to travel down and towards left. So this is my net impulse direction, because the maximal muscle mass, my left ventricle, will draw the net cardiac impulse towards it. So the cardiac impulse travels from the right and superior region of the sinus node to left and inferior region of the left ventricle. That's why the leads facing the right ventricle will have that negative complex, whereas the leads facing the left ventricle will have the positive complex, because the impulse is going to go from the right side towards the left side. As I told you in the previous slide, if the impulse goes away from one particular lead, that lead will show negative complex. The impulse goes towards a lead, that lead will show a positive complex. That's why in a normal electrocardiogram, your V1 is predominantly negative and V5, V6 is predominantly positive, because impulse travels from right to left and also from superior region to inferior region. So that's why the normal configuration of your QRS complex in a normal ECG. Now you look at the normal ECG, you can understand and imagine your P, Q, R, ST and so on. So whenever you see a P wave, atrial depolarization, PR segment is actually the AV nodal delay. Your QRS complex is the ventricular depolarization. ST segment is the gap, and the T wave is ventricular repolarization. Then you have a TP segment, which is the distance between the end of depolarization and the beginning of ventricular repolarization. What are our right and superior leads? Our right and superior leads are the lead AVR and lead V1. So the impulse is going to go away from my right and superior leads to left and inferior leads. That's why in a normal ECG, my AVR and V1 are predominantly negative. My AVR and V1 is predominantly negative because the impulse is going to go away from superior and also right side leads. And they are going to come towards the left and inferior leads. That's why in a normal ECG, V5 and V6 are positive, and also the inferior leads, especially L2, is also going to be positive, because the impulse is going to come down and left, and the leftward leads, the leads facing the left ventricle are the V5, V6, and the inferior leads are especially the L2. So the impulse will be coming down and left. So that's why in the normal ECG, AVR and V1 is predominantly negative, V5, V6 and L2 are predominantly positive. So that's why we can see now also you can see that how the impulses are, you can see that here whenever I say the tall QRS complexes and the upright P wave in V5, V6, I understand my atrial depolarization and ventricular depolarization is coming towards V5, V6. Whenever I see the P wave and the QRS negative in AVR, I understand my atrial depolarization and my ventricular depolarization are going away from lead AVR. Whenever I see a very small equiphasic complex like AVL, I understand the impulse is going perpendicular to lead AVL. So that's why in your ECGs, some leads are positive, some leads are negative, and some leads are equiphasic, depending upon how the impulse is coming towards it, leaving it, or going perpendicular towards it. So now we have understand the normal ventricular depolarization travels from superior and right region to inferior and electrode region. That explains why my left and inferior leads are positive, why my right and superior leads are going to be negative. So with this, we have understood the first topic. We have already seen the conduction system of the heart. We have seen how to derive the PQRST complex. We have understood there are 3 waves and 3 lines, and the waves represent the ionic movement, and the lines represent the conduction or the delay in a particular area. And also we have understood how the impulse travels in the net cardiac impulse, which is called the vector, travels inside the heart, and that explains why in my particular normal ECG, why certain leads are positive, certain leads are negative. So having understood the basic things like conduction system and depolarization, we go on to the next topic, which is called the lead system of the heart. The lead system of the heart is a very complex topic because the understanding the lead system of the heart is primarily based on physics only. So because you have to understand this, how these electrodes are connected to a particular positive pole or the negative pole of the ECG machine. The ECG machine is basically a galvanometer, nothing but a galvanometer. So the lead system are primarily designed to actually, why the lead system are designed to see the various surface of the heart. I told you the purpose of electrocardiogram is to see all my cardiac myocytes, wherever they are. They are depolarizing normally and repolarizing normally. So that means I have to have a system by which I have to see all the surfaces of the heart. So the lead system helps me to see all the surfaces of the heart. The leads are divided into the 12 leads are divided into chest leads and limb leads. In limb leads, you have bipolar leads and unipolar leads. So the unipolar leads are 3 and the bipolar leads are 3 in limb leads, whereas all your 6 chest leads are unipolar. I tell you what is the difference between unipolar and bipolar lead, but at this point in time, you have 12 leads, 6 are limb leads, which are divided into 3 bipolar and 3 unipolar. All my 6 leads are unipolar. That means I have 9 unipolar leads and I have only 3 bipolar leads. There is a lot of difference between an electrode and a lead. The electrode and lead are not same. Electrode is a physical object. You have the metal plate or the chest bulb where you apply with a gel on the patient's skin to get the electrical activity of the heart from the patient to the machine. Whereas lead is not a physical object. It is an imaginary line through which we understand the current is passing from one area of the heart to the other area of the heart. So lead is an imaginary line, electrode is a physical object, on the leads we have 12 leads. Now we understand what is a bipolar lead. In a bipolar lead, the 3 bipolar leads are lead 1, lead 2 and lead 3. These are the 3 bipolar leads. So the bipolar leads, what we do this. So for example, if I ought to get any electrical recording on your ECG paper from your ECG machine, which is a galvanometer, you have to connect something to the positive pole and something to the negative pole. Then only you will get the circuit completed and you have the electrocardiograph recording on your ECG paper. So that means for each one of the leads, we must know how the leads are connected to the what is connected to the positive pole of the machine, what is connected to the negative pole of the machine. Bipolar leads are the leads where one arm is connected to the positive pole and another arm is connected to the negative pole. So that means you are going to see the electrical activity between the two arms or the arm and the legs. So the two parts of the body is connected between positive pole and the negative pole. That's why they are called the bipolar leads. Whereas in lead 1, for example, I'd say lead 1, the negative pole is connected to the right upper limb and the positive pole is connected to the left upper limb. So the lead 1 is a horizontal activity. Horizontal. So whenever I see lead 1, I see the electrical activity going from right to left in a horizontal direction. That is the lead 1. Whereas for lead 2, the negative pole is connected to the right arm and also the positive pole is connected to the left arm. Left lower limb. So the right arm to the left lower limb. So the impulse here is coming down and towards left side. So before we go into further, I just want to say that in all my slides, this side of the slide is left and this side of the slide is right. So whenever I say this like this, that means my impulse is going towards left side. So down and inferior is the line of imagination for my lead 2. Whereas lead 3, negative pole is connected to the left upper limb, positive pole is connected to the left lower limb. Now my line of imagination for lead 3 is coming down and towards right side. So when you look at the 3 bipolar leads, the line of imagination for L1 is right to left horizontal, whereas lead 2 inferior and towards left. For lead 3, it is inferior and towards right. So here it is easy because in a bipolar lead, you are going to connect the two aspects of your body to the negative pole and positive pole. You get the line of imagination between two aspects of the body. So this construct a triangle which is called Einthoven's triangle, which is produced by the horizontality of L1 and inferior and left of L2 and inferior and right of L3. So these are the bipolar leads. Whereas the unipolar leads, what I'm going to get is what is happening below that particular lead. For example, I want to record AVR. I see what is happening below AVR. For example, I record AVL. I see what is happening below AVL. And AVF, what is happening below the foot. So these are unipolar leads are not going to give you the differences of electrical activity between two parts of the body. You are going to see only one part of the body, especially on that particular lead, what is happening. That's why they are called the unipolar leads. They are going to tell you what is happening below that particular lead and not between the two parts of the body. So here also you must know that the line of imagination for unipolar leads, the line of imagination for unipolar leads starts from the center of the heart. From the center of the heart to the right upper limb is called the AVR, which is going to give you the right and superior surface of the heart. It gives you the electrical information of the right and superior surface of my heart. Whereas my AVL is from the center of the heart to the left upper limb, give me the left superior surface of my heart. So it is a left higher superior surface of the heart, which is seen, this is a left and superior surface, and this is a right and superior surface, which is given by AVL. Whereas AVF is going to give me the downward or the inferiorly vertically downward vector, that is from the center of the heart down vertically to the left foot is lead AVF. So the AVF is going to give me left horizontal or vertical, down is lead AVF. Towards right is AVR, towards left is AVL, and towards vertically down is going to be AVF. So when you look at all the systems, all the 12 leads now, you can understand now, my lead 1 is from right to left horizontal. My lead 2 is left and inferior. My lead 3 is right and inferior. My AVR is from the center of the heart to the right upper limb, and which is going to give me the right superior surface of my heart. Whereas AVL is from the center of the heart to the left upper limb, which gives me a left superior surface of my heart. Whereas what I told you about the inferior leads. Inferior leads are lead 2, lead 3, and AVF, because as you can see, these 3 leads, the line of imagination is inferior. Lead 2 is down and left, lead 3 is down and right, and AVF is dead vertical down. So that's why these 3 leads are called inferior leads, not because they are inferior to other leads. They give the inferior surface of the heart, and also the line of imagination for them is directed inferiorly. And also you call the L1 as a horizontal lead. because the line of imagination for L1 is right to left, which is horizontal. So that's why the three leads here are called the inferior leads, which are going to give the inferior surface of your heart. The AVR is going to give you the right and superior surface, whereas lead AVL is going to give you right superior surface of my heart. So when you put all the 12 leads, all the 6 limb leads, they are working like a cameras. So for example, I look at L2, AVF and L3, which are the inferior surface. These 3 leads give the inferior surface of my heart, whereas AVL camera is looking at my left, the L1 along with the L1 is horizontal and towards left, and AVL is left and superior. So along with L1 and AVL, I look at the high left lateral surface of my heart, whereas the AVR, I am looking at the right superior surface of my heart. So this group of leads, what I have seen the inferior surface, I have seen the left superior surface, I have seen the right superior surface. Now it is a time to see the anterior surface. So the anterior surface is seen by the chest leads. The chest leads are once again unipolar leads. Once again, the line of imagination is going to come from the center of the heart to V1, center of the heart to V2, and so on. So the important thing about the ECG interpretation, the most important prerequisite for an ECG interpretation is correct ECG recording. So somebody has to give you the correctly recorded ECG, then only you can interpret with your excellent knowledge. So for that, the correct recording is very important. For the correct recording, the correct connection of the limb leads to the appropriate limbs, as well as the positioning of the chest electrodes in that particular place is very, very important. So let us see how we are going to place this chest electrodes. So the V1 is placed on the 4th intercostal space on the right side. The V2 is placed on the 4th intercostal space on the left side. The 4th intercostal space can be counted from the Lewis angle, which is the just a depression from the manubrium to the junction of the sternum. So that tells you it's the 2nd intercostal space. From the 2nd intercostal, 3rd and 4th, the V1 is on the right, V2 is on the left, and V4 is placed on the 5th space in the mid-clavicular line, and V3 is placed between V2 and V4. So V3 has got no place, a specific place. It is placed between V2 and V4. V5 is placed on the 5th intercostal space in the anterior axillary line, and V6 is placed on the 5th space on the mid-axillary line. So V4, V5, and V6 are in the 5th spaces. V1 and V2 are in the 4th spaces, and V3 is placed in between. So for example, when you go and look tomorrow, your ECG technician, so to see or to learn or to know whether ECG technician has got the right knowledge of ECG recording, what you have to see is how he's placing the lead V3. So ask him to place V3. If he goes and places V3 directly in one place, he does not know anything about ECG recording. So to place V3, what one should do is they must place V2 first, then V4, then place V3 in between. Then only you know that ECG technician has right knowledge of ECG recording. So please make sure that your technician and paramedical staffs are placing the electrodes in correct places to record the ECG, because placing these electrodes one space above or below grossly distort the QRS complexes and entire electrocardiogram, give you a wrong diagnosis and a plan of management. So now, having seen the 6 chest leads, let us see how these 6 leads are going to give me the information about the surface of the heart. I already seen what? I have seen the right superior surface through L1 and AVL. I have seen the left superior surface. I have already seen the inferior surface through L2, L3, AVF. Left superior surface I have seen. The right superior surface I have seen. Then what surface I have to see from the chest electrodes. So, chest leads. So the V1 is placed on the right ventricle. So the V1 gives me idea about the right ventricle of the heart. V2, V3, V4 is placed on the interventricular septum and the left ventricle. So the most important surface of the left heart is shown by V2, V3, V4, which is the septum and the antral wall. Whereas V5, V6 give me idea about the horizontal anterolateral of the heart. Whereas L1 AVL gave me the left superior surface of my heart, whereas V5 and V6 gives me information about the horizontal anterolateral surface of the heart. So along with V5, V6, L1 and AVL, I look at entire the lateral surface. Through L2, L3 AVF, I look at the inferior surface, and through the V1, I look at the right ventricle, V2, V3, V4, the anterior surface and ventricle, and V5, V6, anterolateral surface on my heart. So now look at the everything. So this is where you have to place the chest electrodes, V1, V2 on the right side, on left side, on the fourth space, V4, V5, V6 on the left surface, and V3 in between. And of course, we have seen now that how this leads are going to give you the various surface of the heart. And of course, in certain situation, you have to record the right side of the leads. There are three situations. So you have to record the right side of the leads. One is when the patient has got a dextrocardia. The other situation is in a complex congenital heart disease. You have to record the right side of the leads. Whenever the patient has got inferior infarction, to diagnose right ventricular infarction, you have to record the right side of the leads. So three situations, you have to record the right side of the leads. When you are suspecting the posterior infarction and your ECG is not very classical, you have to record V7, V8, and V9. V7 is placed on the posterior line, posterior axillary line. V8 is placed on mid-scapular line, and V9 is placed on paraspinal line. And very rarely we record V7, V8, and V9 to diagnose post-wall infarction. So these are the additional leads we record very rarely, which are the right side leads, and also the posterior leads to diagnose post-wall myocardial infarction. So now you can look at the entire lead system through this three-dimensional diagram to understand how we are going to get the information through the various surface of the heart. When you look at AVR, it gives the right superior surface on my heart. When you look at L1 and AVL, it gave me the left superior surface on my heart. When I look at L2, AVF, and L3, the L2 is down and left, L3 is down and right, and AVF is dead vertical. It gave me the inferior surface of my heart. V1 gave me the right ventricle. V2, V3, V4 gave me the anteroventricular septum and also the anterior wall. And V5, V6 gave me the horizontal anterolateral surface of my heart. And with this, I have seen almost all surface of my heart. So I don't see the posterior wall. The posterior wall changes are either interpreted by the opposite changes which are happening in the anterior leads, such as V1, V2, and V3, or very rarely we can record the posterior surface by V7, V8, and V9. Having seen these surfaces, now we look at how we can diagnose a particular artery is blocked in an acute coronary syndrome, especially when there is an ST elevation myocardial infarction. So now, if I know what artery is surfacing this particular surface, if the surface leads, that particular leads which are representing that particular surface are showing ST changes, especially ST elevation, I know this particular artery is blocked even without doing an electrocardiogram. So whenever I look at the inferior surface is supplied by the right coronary artery. L2, L3 AVF is the right coronary artery. Right ventricle is also supplied by the right coronary artery. So right ventricle is also supplied by the right coronary artery. The anterior surface and the interventricular septum is the most important aspect of your ventricle, is supplied by the most important artery of all, left anterdescending artery. Whereas my entire lateral surface, what are the entire lateral surface? V5, V6 is anterolateral surface. L1 AVL is high lateral surface or supralateral surface. The entire lateral surface of V5, V6 and also L1 AVL is supplied by circumflex artery. So whenever I have a ST elevation inferior leads, I know right coronary is blocked. Whenever I have ST elevation V2, V3, V4, I know the left hand descending is blocked. Whenever I have ST elevation V5, V6, L1 AVL, I know circumflex is blocked. So that's why now we have understanding so this is the purpose of lead system. We not only looked at the various surface of the heart through the various leads, but also we are able to identify a particular artery perfusion territory so that when an acute coronary syndrome, we have some idea which artery is the culprit artery to produce that particular acute coronary syndrome, especially ST elevation myocardial infarction. So when I give everything together in the single slide, so when you look at L1 AVL, V5, V6, L1 AVL is superior lateral left lateral surface, V5, V6 anterolateral surface. So these are the group of leads. This is a surface, this is a perfusion artery. So L1 AVL, V5, V6, entire lateral wall separated by circumflex. L2, L3 AVF and also V1, which is the right ventricle supplied by the right coronary artery. V2, V3, V4, which is the intraventricular septum and antral wall supplied by the left-handed descending artery, and also the posterior wall, which can be seen either through the reciprocal changes in V1, V2, or directly recording from V7, V8, and V9, can be either supplied by circumflex or right coronary artery, depending upon its dominance. So now we have to also know about the naming of the individual leads. Although we have looked at the leads as the group of leads here, and also like L1, AVL, V5, V6, we must also know the individual naming, especially of the limb leads. It's a very, very important diagram you have to understand. If you understand this diagram, the other chapters are going to be very easy. So what I have done is I have put the heart in the middle. You can see the heart is slightly pointing towards my left side. And it's, you can see that electrical impulse which is starting on the right and superior region, traveling down to my left and inferior region. So this is a normal vector or the normal net depolarization of the heart. And I have put my limb leads around this heart. So L1 is the right to left. So right to left horizontal. So that's why L1 is called the horizontal lead. Whereas my AVF is a dead vertical lead. So AVF is called the vertical lead. The L2 is in between L1 and vertical lead, L1 horizontal and AVF vertical lead. It is called intermediate lead. What is the imagination, line of imagination for L3? Inferior and right. So that's why the L3 is called the right-sided lead. Whereas AVL, I am going to connect the center of the heart to left upper limb, superior and left. That's why the AVL is a left-sided lead. Whereas AVR is no man's land. So this is the naming of the individual leads. L1 is horizontal, AVF is vertical, L1 is intermediate, L3 is right-sided lead, AVL is, so L3 and AVL are exactly opposite leads. And also the lead AVR, which is called the no man's land. I tell you why AVR is called the no man's land next. So here what happens is going to happen is, look at the impulse. The impulse is starting from the sinus node and it is going to come down and towards left to the AV node, depolarizing the atrium. So the atrial depolarization is going down and left. It is going away from lead AVR. So whenever a complex is going to go away from a lead, it will show a negative complex. So because the atrial depolarization is going away, the P wave is negative in AVR. Then look at the ventricular depolarization. It is going to go down and left towards my left ventricle. Once again, it is going to go away from AVR. That's why ventricular depolarization represented by the QRS complex is negative in AVR. Whenever the QRS is negative, my T wave is the same direction. So the T wave is also negative in lead AVR. That's why in a normal electrocardiogram, the P wave is negative, QRS is negative, and the T wave is negative because all the waves are going away from lead AVR. So because everybody is running away from AVR, it is called no man's land. So whenever the P wave is positive in AVR, whenever the QRS is positive in AVR, you must be terribly worried. Because what does it mean? The impulse which is instead of coming down and left, whenever it is going to travel in the opposite direction towards AVR, it is going to be a grossly abnormal depolarization. So this is the rare instant, very rare event in your life where when something is negative, you are very happy. So whenever everything is negative in AVR, you are happy because the impulse is going in right direction. Right. This is what I'm going to say, that my atrial depolarization is going to go away from AVR. Ventricular depolarization is going to go away from AVR. So that's why my AVR shows everything is negative. So that's why I told you the right and superior leads. AVR is predominantly negative. V1 is also predominantly negative because the impulse travels not only from superior to inferior region, it also travels from the right to left. That's why in a normal electrocardiogram, AVR and V1 are predominantly negative QRS complexes, and V5, V6, and also the inferior lead of L1 is going to be predominantly positive QRS complex. Now we can understand through the lead system also. Now, how to look at the ECG from tomorrow? So you may be looking at the ECG just like L1, L2, and so on. So don't look them like that. So first you have to look at lead 1 and AVL. So when you are looking at lead 1 and AVL, you are looking at the left superior surface of the heart, which is supplied by circumflex artery. Along with lead L1 and AVL, always look at V5 and V6. So V5 and V6 give you the information about the anterolateral surface of my heart. So these four leads are going to be representing the lateral surface of my heart, and also they represent the circumflex perfusion territory. Then I look at L2, L3 and AVF along with V1 because all these three leads are going to be supplied by my right coronary artery, lead 2, lead 3 AVF along with the V1 which represent the right ventricle. Then I look at V2, V3 and V4 for the most important surface of my all, that is the left ventricle and interventricular septum, and that is represented by the V2, V3, V4. This is how the ECG should be looked. So first the lateral wall, then the inferior wall, and also the right ventricle and the interventricular septum and anterior wall. So now you have understand from this diagram the surfaces and also the perfusion territories. You can look at here the right coronary artery which is running on the right atrioventricular groove not only supplies the right ventricle which is the area of V1 and also supplies the inferior surface which is lead to AVF and L3. So this is right coronary artery. Whereas LAD which is running on the anterior interventricular groove is going to supply your interventricular septum and supply the entire anterior surface of the left ventricle, which is represented by the V2, V3 and V4. Whereas my circumflex, which is running on the lateral surface of my heart, is going to be supplied by represented by the V5, V6 and also L1 and AVL. So my lateral surface is going to be shown by the circumflex artery by the 4 leads which are V5, V6 and also L1 and AVL. So this is how we understand the surfaces from the lead, and also we can understand how the artery perfusion is representing the particular surfaces. Now, next what we are going to do is we have seen that how to look at the electrocardiogram. We have seen the P wave QRS complex. Now, we must know whether this particular wave is normal or abnormal. And if it is going to be abnormal, what does it represent? What abnormality I should think of? For that, we have to measure each one of our waves in the ECG paper. So for that, we have to understand the ECG paper. The ECG paper has got the small squares and big squares. So there are five small squares which are arranged horizontally as well as vertically inside each one of your big squares. So before reading an electrocardiogram, you must always look at this vertical bar, which is called the standardization. In a normal recording or a routine recording of electrocardiogram, this vertical bar should have 10 small squares inside or 2 big squares inside. This is called the normal standardization, which is called either 1 millivolt standardization or 10 millimeter standardization. So when you record a standardization of vertical bar, which includes the 10 small squares inside, each one of your small squares vertically is 1 millimeter. Vertically, you measure the amplitude of the wave. So each one of your small square is 1 millimeter. Each one of your big square is 5 millimeter in height. Whereas the ECG is recorded at the speed of 25 millimeter per second. So when you record the ECG at this particular per second, you measure the time or the width of the particular complex horizontally. Horizontally, the time is measured. When the ECG recorded at 25 millimeter per second, each one of your small square is 0.04 second and each one of your big square is 0.2 second. So vertically, the small square is 1 millimeter, big square is 5 millimeter. Horizontally, small square is 0.04 second and big square is 0.2 second. So this is how the measurements are made. First, we look at the P wave measurement. P wave is measured from the base of the baseline to the peak of the P wave. For P wave, you have to remember the 2.5. The 2.5 is the number for P wave. So if the P wave is taller than the 2.5 in lead 1, for example, before that, you have to understand how to look at the P wave. You have to look at lead 2 and V1 for the P wave abnormalities. In L2, both right atrial depolarization, right atrium to be first one to be depolarized because the sinus node is in the right atrium, then the left atrium is depolarized. Because both depolarizations are going to come down, in lead 2, both my right atrial, which is the initial part, and the left atrial part going to be positive. So L2, both atrial depolarization are going to be positive because both atrial depolarization are going to come down towards the inferior lead. Whereas it's not the case for V1 because in V1 is a right and anterior lead. The right atrial depolarization is right and anterior, which will produce a positive initial deflection of the P wave in V1. Whereas left atrial depolarization is later and it is going to go left and posterior, which is going to go away from my V1, which will produce the terminal negative component of the P wave in V1. So normal P wave in V1 is an equiphasic P wave, where the initial positive represents right atrial depolarization, terminal negative complex represent left atrial depolarization. So whenever my P wave is tall, that means P wave as the height of the P wave is more than 2.5 millimeters in L2, it is right atrial enlargement. Tall P wave represent right atrial enlargement. So naturally, because my initial component is going to be exaggerated in right atrial enlargement, my initial component is exaggerated in V1. So the P wave is taller in L2 of more than 2.5. My initial component is taller in V1. I am dealing with right atrial enlargement. So abnormal in height is right atrial enlargement. Whereas look at here, the P wave is abnormal in width. My height is normal, but look at the P wave is occupying more than 2.5 small squares horizontally, and it has got a notch in between the right and left atrial depolarization. So whenever I have the white P wave in L2, which looks like M in L2, it is likely to be left atrial enlargement. Whereas my terminal negative component in V1 is going to represent left atrial depolarization. I have a deep and broad negative component of P wave in V1, which represents left atrial enlargement. So tall P wave is a right atrial enlargement. Initial tall component in V1 is right atrial enlargement. White P wave or M-shaped P wave in L2 is left atrial enlargement. Terminal deep negative component of P wave in V1 is a left atrial enlargement. So now we come to the PR interval. The PR interval represents the entire, I told you in the first lecture, that entire PR interval represents the atrioventricular conduction time. So the PR interval tells you what is the time taken for my sinus impulse ultimately to reach the ventricular muscle cell. So this will include the atrial depolarization, AV nodal delay, and also the beginning of the ventricular depolarization. So this is the PR interval. Normal PR interval is the 12 and 21, 0.12 to 0.21, which means it should not be shorter than the 3 small squares and it should not be longer than 5 small squares. So that's what it means. So when it is shorter than less than 0.12, it is called short PR. If it is more than 0.2 or more than 5 small squares horizontally, it is a long PR or PR interval is prolonged. Where do I have the short PR interval? In some people, there is an anomalous pathway which is directly connecting the atrium and ventricle, bypassing the AV node. So whenever there is an anomalous pathway which is directly connecting the atrium and ventricle, which is bypassing the AV node, the impulse will go through the bypass pathway without the delay. If there is no delay, as you can see, my PR interval will be short because my AV node is bypassed. So whenever my PR interval is short, like this, I don't have the PR segment at all. My P wave, then the QRS starts. So whenever my PR interval is short, I have to think of an anomalous pathway like a Kent pathway, which is bypassing the AV node. The short PR interval is a component of the Wolff-Parkinson-White syndrome, where anomalous pathway is going to bypass the AV node. Whenever my PR interval is long, it is more than 5 small squares. You can see that it is more than, it's a 5 small squares here. It is more than 5 small squares. It is a first degree atrioventricular block, which means my AV node is giving excessive delay. My PR interval is short, the AV node is bypassed. My PR interval is long, my AV node is, or the AV conduction, I will not say AV node alone, my atrioventricular conduction is prolonged. It can be prolonged at the AV node or the distal conduction system. But anyway, it takes a long time for my atrial depolarization to reach my ventricular muscle. So somewhere in the conduction system, especially in the AV node or below, the impulse is delayed. So the prolonged PR interval is first degree atrioventricular block. Then we come to the QRS complex. The QRS complex can be abnormal in its width or its height. So it can be the measurement of the height is from the QRS, from the baseline to the top of the QRS, and the width is from the beginning of the Q to the end of S wave is the width measurement. So normal amplitude of the QRS complex, especially in V5, V6, should not be more than 26 millimeters. So whenever the QRS is taller than more than 26 millimeters in V5, V6, I have to suspect left ventricular enlargement. Whereas I told you already, In V1, I will have a predominantly negative QRS complex because the impulse is going away from V1 towards V5, V6. Let us say I have a tall R wave in V1. What does it mean? It means my right ventricle, which has assumed more muscle mass than the left ventricle, pulls the net vector towards it. So whenever there is a right ventricular enlargement, my net impulse, instead of going down and towards left, will come towards right, resulting in a tall R wave in V1. So whenever I have a tall R wave in V1, it may represent a right ventricular enlargement. Whenever I have a tall R wave in V5, V6, it may represent left ventricular enlargement. My QRS width, that is the beginning of the QRS to the end, should be less than 0.08 second. That means my entire QRS duration is only 2 small squares. This is what I told you. Why the QRS is so narrow? Because all my ventricular muscle cells are depolarized by my specialized conduction system, which includes the bundle of the bundles and also the Purkinje fibers. So that's why my QRS is narrow. My QRS is less than 0.08 second. So look at this ECG here. I have a very tall QRS in V5, V6, more than 26 millimeter. That means my leads which are facing the left ventricle are showing an exaggerated QRS complexes. Exaggerated depolarization means there's a lot of muscle mass there. So that is the left ventricular enlargement, V5, V6 more than 26 millimeter. Whereas look at here the V1. Now look at the normal V1. It's predominantly negative. The R-S ratio is less than 1. That means the R wave is very small, the S wave is very deep. Look at here. I have a predominantly positive complex in V1. So whenever my right ventricle muscle mass is going to be more than my left ventricle muscle mass, it will pull the net vector towards it, net impulse towards it, resulting in a tall R wave in V1. Whenever your R wave in V1, which is going to be more than 7 millimeter, or the R-S ratio in V1 is more than 1, which means the R wave is taller than the depth of the S wave, you must suspect a right ventricular enlargement. So abnormal in height represent ventricular enlargement. Abnormal in width. Now we can see that here. Why my ventricular depolarization is so narrow? Because all my ventricular muscle cells are depolarized by specialized conduction of the heart. That is one point. Second point is because the right bundle and the left ventricle is intact, both ventricles are depolarized simultaneously. There are two reasons why your QRS is narrow. One, both ventricles are depolarized simultaneously. Second, all the ventricular muscle cells on the left side, on the right side are supplied by the specialized conduction system of the heart. Let us imagine I have a block in one of the bundles. One of the specialized bundles I have blocked. Let us say I have a block in my left bundle. So what the impulse will do is it will come through the right ventricle first through the intact right bundle, then travel through the muscle to depolarize my left ventricle. So left ventricle has to be depolarized, then only it can contract. So left ventricle ultimately has to be depolarized, although the bundle to the left ventricle is blocked. Now you can understand, normally the impulse is going to travel at 4 meters per second if my intact conduction system. If it is going to go through the muscle, it is going to travel through 0.5 meters per second. That means what? My QRS is going to be wide. So my QRS, the depolarization takes a long time to end because one portion of my ventricular muscle is going to have a impulse which is getting slowly. And the second point why the QRS is wide in a bundle branch block is that my ventricles are not depolarized simultaneously. My right ventricle is depolarized first, and the ventricle for which the bundle is blocked is depolarized late and depolarized through the muscle, resulting in a wide QRS complex. So whenever I have a wide QRS, you can see that here, almost simultaneous depolarization of right and left ventricle here, whereas here, the right ventricle depolarization and the left ventricle at different point. So whenever I have a wide QRS complex, the most common cause of wide QRS complex. So whenever QRS is wide, automatically I must assume my one portion of my ventricle is not supplied by the specialized conductions of the heart. Now you are going to see the examples of the bundle branch blocks. You can see it is not a QRS is narrow. You can see the QRS is occupying almost 4 small squares. So whenever I have the wide QRS complex, and even there a wide QRS complex, I have a terminal R wave in V1. For I have a wide QRS complex, I have to look at where my terminal R wave is. If my terminal R wave is on the right side lead like V1, it is right bundle branch block. Whereas look at here, I have a wide QRS complex. My terminal R wave is not on the right side. My terminal R wave is on the left side. So this is left bundle branch block. So having diagnosed bundle branch block, what you have to see is where is my terminal R wave. The terminal R wave is in the right side lead, it is right bundle branch block. If the terminal R wave is in the left side lead, it is left bundle branch block. Sometimes you may not have the QRS at all from V1 to V6. That means your entire ventricular muscle is damaged and scarred in an anterior wall myocardial infarction, extensive anterior wall myocardial infarction. There are no healthy cells to depolarize. So you have no R wave in an extensive anterior wall myocardial infarction. So increased amplitude will tell you ventricular enlargement. Then you can have in some QRS, some ECGs, you have a low voltage QRS complexes, which are defined as the entire average QRS complex in the limb leads less than 5 millimeter in height, chest leads less than 10 millimeter in height. So this is called the low voltage QRS complexes. So when you have a low voltage QRS complexes in limb leads as well as in chest leads, you have to suspect three conditions. One is mixed edema, second is pericardial effusion, and third is actually mixed edema, pericardial effusion, and also you can have obesity where the limb and chest leads are going to be low voltage. Increased width of the QRS complex bundle branch block, absent R wave can be myocardial infarction. Then the ST segment. ST segment is the most crucial segment and where the acute coronary syndromes are going to be represented. So it is the most crucial symptom of all the ECGs. So this is called the widow-making segment, because if you don't manage these ST segments properly, you will create more widows. So all the acute coronary syndromes are going to be represented in acute coronary syndrome as the ST segment. So the ECG alone will tell you what is the type of acute coronary syndrome and what management you have to give to that particular patient. So coronary syndromes are divided into non-ST elevation acute coronary syndrome and ST elevation acute coronary syndromes. In a non-ST elevation acute coronary syndrome, so what happens in all acute coronary syndromes, there is either a plaque erosion or a plaque rupture, atheromatous plaque rupture. So when the plaque ruptures and the thrombus is formed in a non-ST elevation ACS, the thrombus which is formed is only platelet rich, and also it is going to critically occlude an artery and not totally occlude an artery because it is only a platelet rich thrombus. So whenever there is a non-ST elevation ACS due to white thrombus which is rich in plot, which is only a critical occlusion, there is a predominantly subendocardial injury. So the patient will come with acute chest pain with ST segment depression. So whenever the patient comes with acute chest pain with ST segment depression, it means non-ST elevation ACS due to critical occlusion and the thrombus which is rich in platelet. And here you will never thrombolize these patients because the thrombus is not totally occluding and the thrombus is not rich in platelet. And that's why how to identify that will be the ST segment depression. Whereas whenever the plaque ruptures, it not only stimulates platelets, but also stimulates coagulation system. There is a huge fibrin also which is getting formed along with the platelet and fibrin thrombus, which will a large thrombus here, which will totally occlude a coronary artery, not allowing any blood flow to the distal myocardium. So this is called the red thrombus because of the fibrin, and it is a total occlusion. So whenever there is a total occlusion with a red thrombus, what you have is a subepicardial injury, which is going to produce ST segment elevation. So the patient comes with acute chest pain with ST segment elevation. It is total occlusion due to red thrombus. The distal myocardium is dying every second. So you have to immediately thrombolize this patient or do a primary PCI. So this is the only situation. This is the only investigation which will tell you not only it is an acute coronary syndrome, what type of acute coronary syndrome it is, and what is the pathophysiology, what is the thrombus involved, and what is the management you have to offer in that particular acute coronary syndrome. Here, echocardiogram is not going to help you. You can even a coronary angiogram may not help you. So here, the patient is coming to acute chest pain with a ST segment elevation. Immediate understanding is I have an acute occlusion due to red thrombus, and ST segment elevation is acute thrombus to red elevation. Look at where the ST elevation is, V2, V3, V4. So I have definitely, this is supplied to the left antedescending artery. So here definitely I know not only acute coronary syndrome, it is not only acute occlusion, not only total occlusion, not only red thrombus, and it's also of the LAD territory. So here I have to do a thrombolysis or a primary PCI. Whereas this patient comes with acute chest pain with a significant ST segment depression. There is no ST elevation in two leads, significant ST segment depression. So here I know acute occlusion all right, but critical occlusion with a white thrombus. So here I will not thrombolize this patient. So this is the idea which is given by your ST segment in acute coronary syndrome. Then we come to the T wave. T wave, first it should be normal in direction. That means it has to go along with the QRS. So whenever the T wave is inverted, it is abnormal. The T wave inversion can be ischemia or non-ischemic T wave inversions. The height of the T wave is 40% of the preceding QRS. So whenever the T wave is more than 40% of the previous QRS, it is tall T wave. Whenever the QRS is less than 20, whenever the T wave is less than 20% of the QRS, it is the low voltage T wave. So it can be a tall T wave or it can be a low voltage T wave. So whenever I told you about whenever the T wave is inverted and going in the opposite direction of the QRS complex, immediate understanding is your depolarization and the repolarization are happening in the same direction. So the T wave inversion represents there is abnormal direction of repolarization. Instead of starting from epicardium, it is starting from the endocardium to epicardium. That's why the T wave can be negative, which can be ischemic or non-ischemic. Then, of course, you have the tall T waves. The tall T waves are the T waves which are more than 40% of the preceding QRS complex, and it is a tall T wave. You look at the tip of the T wave and the base of the T wave. So if your tip is very short and the bare and you have the very narrow base, you have to place your finger on the top of the T wave. If the T wave pricks you, such a needle sharp T wave is hyperkalemia. Very sharp apex with a narrow base is hyperkalemia. Whereas if the patient comes with acute chest pain, when you have a broad T wave with a blunt apex, it is likely to be a subendocardial ischemia, a presentation of an acute coronary syndrome. So whenever there is a tall T wave, look at the apex and the base. Needle sharp apex, narrow base is hyperkalemia. Broad base, blunt apex is acute ischemia. Whenever you have a low voltage T wave, look at the U wave. U wave is a wave which is coming after the T wave. So whenever the low voltage T wave is represented by the T wave which is less than 20% of the preceding QRS complex, whenever there is a low voltage T wave is accompanied, here you have a low voltage T wave which is accompanied by a large U wave, it is hypokalemia. Whereas whenever your low voltage T wave is not accompanied by U wave, it is a non-specific T wave abnormality. So whenever the T wave is less than 20% of the R wave, look at associated U wave. When there is a U wave, it's hypokalemia. When there is no U wave, it is non-specific abnormality. So then we have the QT interval, which is starting from the Q wave to the end of the T wave. The QT interval should be seen and also should be corrected to the heart rate. So the heart rate correction also given by your ECG machine. So this is the QTC is the corrected QT interval, by which we mean that the QT is corrected for the prevailing heart rate. The normal QT is between 320 to 470 or 500. It should not be more than 500. So more than 500 QT is prolonged, and whenever the QT is prolonged, you must whenever the patient comes with the syncope or seizures, the one interval you must always see will be the QT interval. A long QT interval can produce a dangerous arrhythmia called torsades pointus and can produce recurrent episodes of syncope and seizures. So long QT interval can be congenital, or in the adults it can be a lot of drugs can produce long QT interval, and also electrolyte abnormalities can produce long QT interval. So whenever see the QT interval, whenever there is a syncope and seizures, look at the QT interval, which is anything beyond 500 milliseconds of QT interval is going to be abnormal. So now we have seen the P, now summarize our measurements. The P wave, tall P wave is right atrial enlargement, wide P wave is left atrial enlargement. PR interval is short in pre-excitation or anomalous pathway. PR interval is long in first degree atrial ventricular block. My QRS is more than 26 millimeter on the left side leads, left ventricular enlargement. Tall R wave in V1 more than 7 millimeter right ventricular enlargement. Whenever my QRS is more than 0.08 seconds, QRS wide, I have to suspect bundle branch block. ST segment elevation is acute occlusion, total occlusion, red thrombus. ST elevation, I have to thrombolize. Whenever there is ST segment depression, acute occlusion, critical occlusion, white thrombus, I will not thrombolize. Whenever the T wave is tall more than 40%, narrow base, sharp apex, hyperkalemia, broad base, blunt apex, acute ischemia. Whenever there is a low voltage T wave, I have to look at the U wave. U wave is present, hypokalemia. U wave is absent, it is non-specific variation. Whenever my QRS is less, my QT is more than 460, or definitely if it is more than 500, my QT is prolonged. Any patient with syncope and seizures, look at the QT interval. Then the easiest thing is heart rate calculation. the heart rate calculation is done. Why it has to be done is manually. Although your heart rate is given by the machine, still I have to give the heart rate calculation is, for example, look at the patient. The patient has got a heart rate of 40 per minute, but your ECG machine is giving you 91 per minute. Imagine you are giving a beta blocker or a verapamil or an amiodarone to this patient, believing the heart rate is 91 per minute. So the usually what we do is we have to look at the you have to take a lead in which the QRS is seen nicely and take two QRS in the same lead and count either number of big squares or number of small squares between the two adjacent QRS complexes. 1500 by small squares or 300 by big squares will give you the heart rate per minute, and it should be done only for the patient who's got a regular rhythm. Anything between less than 60 brady, anything more than 100 is tachy. Normal heart rate is between 60 to 100 per minute. Sir, this I finished the third lecture. This is the fourth lecture. Dr. Ravi sir. Ravi sir, you there?
Yes, sir. Dr. Pichmani here, sir. Yes, sir.
Sir, yes, sir.
Can you go?
Please, sir. You can go ahead, sir.
Yeah, you can go ahead, sir. You can go ahead, sir.
Thank you. Thank you. So this is the last lecture. We are going to look at the most difficult lecture for many of us. It is going to see the electrical axis. What we are going to see here is, I told you about the net cardiac impulse, which is going to go in a particular direction. So I told you the normal cardiac impulse is travel from the right and superior region to left and inferior region. So because my left ventricular muscle mass is the greatest muscle mass, which will pull the net cardiac impulse towards it. So in the electrical axis, what I am going to see is whether my ventricular depolarization is traveling in the right direction or a wrong direction. If it is going to travel in a wrong direction, what diseases I have to think of? Just like I told you in measurements, if a particular wave is abnormal, what are the things you have to think of? Similarly, when the ventricular depolarization is going in a wrong way, what conditions I have to think of? So that's why in electrical axis, what you are going to see is, we are going to look at in what direction my ventricular depolarization is going to travel. I told you the normal ventricular depolarization is supposed to travel from right and superior region to my left and inferior region. That's why my L1 is positive, V5 and V6 are positive. So this is the normal direction of my ventricular depolarization. So when it's going to be abnormal, so what are the conditions you have to think of? So first of all, for why I have to calculate electrical axis is to know in which direction my ventricular depolarization is traveling and what is the position of the heart, whether it's horizontal or vertical. To diagnose vesicular blocks, it is very, very important, because in addition to bundle branch block, if you have a vesicular block, it means advanced conduction system, and because of that, you can have a complete heart block or stroke attack. And what is the important advantage of knowing axis is to impress others. For example, you take an ECG and say within a second it is 0 degrees and throw away the ECG. People will be terribly impressed by your knowledge, and your image in them go beyond a particular height. So for this, I am going to tell you certain rules. So the axis is usually calculated in a very complicated way, where the patients are actually complicated way. That's why it is very difficult for, that's why in many of us, the electrical axis was an enigma. So that's why we did not learn about ventricular axis. So to calculate electrical axis, look at the limb leads only. I told you the 6 limb leads. I told you also the position and also the naming of limb leads. L1 is horizontal, L2 is intermediate, AVF is vertical, L3 is right, AVL is left, and AVR is no man's land. So look at limb leads only, look at the QRS only. Why you are looking at the QRS? I want to know in which direction my ventricular depolarization is going. QRS is representing ventricular depolarization. Then first step is look at lead 1, 2, and AVF. So if you have lead 1, lead 2, or lead AVF, any one of these 3 leads are going to show the tallest positive QRS complex. What you have to see in this particular limb leads is which of these 6 limb leads are going to show the tallest positive QRS complex. That's what you have to see. Having seen this particular orientation, what next you have to see? In which lead I have the tallest QRS complex. So if my L1, L2, either L1, L2, any one of these 3 leads showing the tallest positive QRS complex, I am dealing with a normal axis. I am dealing with a normal axis because it is understandable. You see, the impulse is starting here and it's going to come down like this. And these are the 3 leads are guarding this region of the left ventricle. My impulse is normal impulse is going to come to this quadrant. So this quadrant is managed by L1, L2, and AVF. So any one of these three leads are showing the total positive QRS complex. I am dealing with the normal axis. Look at this particular electrocardiogram. So look at this electrocardiogram. So look at the limb leads only. So look at the limb leads only. Which lead are the tallest positive QRS complex? L2. So either L1 or L2 or AVF. Any one of these three leads show the tallest positive QRS complex. I am dealing with the normal axis. Here my L2 is showing the tallest positive QRS complex. So I have a normal axis. Then if these three leads are not going to show the tallest positive QRS complex, I look at the other leads. What are the other leads away from these three leads? On the right side is the L3. On the left side is AVL. So I first look at L3. If my L3 shows the tallest positive QRS complex, what does it mean? L3 is the right-sided lead. My impulse is coming down and right. So if the L3 shows the tallest positive QRS complex, I am dealing with the right axis deviation. So what is the opposite lead for L3? AVL. So in the right axis deviation, AVL will show what? The deepest negative QRS complex. So the impulse will be going away from AVL and towards L3. So whenever the L3 shows the tallest positive QRS complex and AVL shows the deepest negative QRS complex, I am dealing with the right axis deviation. Look at this ECG here. L1, L2, L3, AVR, AVL, AVF. See the tallest R wave is in L3 and the deepest negative QRS complex in AVL. So L3 shows the tallest positive QRS complex. I am dealing with the right axis deviation. So L3 is positive, AVL is negative. I am dealing with the right axis. Now it is easy to say left axis, because in left axis, the impulse is going to travel up and towards left. So because it travels up and towards left, and the AVL will show the tallest positive QRS complex, which lead will show the deepest negative QRS complex? It is the L3. So impulse will be traveling down and right towards left and superior. So AVL is positive, L3 is negative. It is a left axis deviation. Look at this electrocardiogram. So first I look at all the 6 limb leads, lead 1, 3, and I have the AVL here. So of all the 6 leads, AVL shows the tallest positive QRS complex. My L3 shows the deepest negative QRS complex. So impulse is going away from the right side leads and towards the left side leads. I have a left axis deviation. So I have finished 5 leads. What is the other lead left? It is lead AVR. If the AVR shows the tallest positive QRS complex, you have a very abnormal axis deviation, because instead of impulse coming down and left, if the AVR is positive, it means the impulse is going right and superior. So it is called the north-west axis, because it is north and west. So north-west axis is lead AVR. So look at this ECG here. None of my 5 leads, L1, L2, AVF is not showing positive QRS complex. L3 is not showing positive. AVL is not showing positive. Only my AVR is showing tallest positive QRS complex. So this is called the northwest axis. So AVR positive is northwest axis. So now I told you within 5 to 10 minutes, the 4 axis. Normal axis is my L1, L2 or AVF. Any one of these 3 leads show the tallest positive QRS complex. And a normal axis, my AVR should be negative. So AVR is negative, but L1, L2 or AVF is showing the tallest positive QRS complex. I am dealing with a normal axis. Whereas my L3 is positive, my AVL is negative. L3 is positive, my AVL is negative. I am dealing with a right axis deviation. If the impulse is coming like this, I am dealing with a right axis deviation. Whereas my AVL is positive, my L3 is negative, I am dealing with a left axis deviation. If my AVR is positive, I am having a northwest axis. So this is how the normal axis. Up to this time, you will be impressing others. Whereas to intimidate others, you have to say the number. So what I am going to say is, for each lead, I am going to assign a number. So if you say normal axis, right axis, he may understand. But you say the particular number, he may be further confused, because he will not know, but the number represents the normal axis or left axis. So ultimately, he will be afraid of you. You may be intimidating him. So instead of saying normal axis, if a particular lead has got the tallest positive QRS complex, I am going to say 3 things. One is, if for example, if L1 is positive, I am going to say 3 things. One is whether the axis is normal or abnormal. Second, what is the number for that particular lead which has got the tallest positive QRS complex? And then what is the clinical implication? That means these three particular points should be known for all the 6 leads. To give the number for a particular lead, we divide the circle, we put the leads in a particular circle and we divide the circle into 2 halves, superior half and inferior half. Inferior half, I have 3 leads, L2, AVF and L3. Superior half, I have 2 leads, AVR, AVL, and the dividing line is L1. Any lead which is inferior will have the positive number. Any lead will have the superior half will have the negative number. And we start with the 0. So, for example, if my L1 has got the tallest positive QRS complex, it's a normal axis, isn't it? Axis is normal. What is my number? Number is 0. So, if the L1 shows the tallest positive QRS complex, it is a horizontal lead, isn't it? Only horizontal heart will have the L1 being the tallest positive QRS complex. So, 3 points about L1 is, I have a normal axis, 0 degrees and horizontal heart. Whereas L2 shows, for example, look at this particular ECG, that the L1 shows the tallest positive QRS complex. So what are the 3 points? That is a normal axis, 0 degrees and horizontal heart. Whereas if L2 shows the tallest positive QRS complex, it is a normal position of the heart. For example, I've told you many times, the normal impulse is likely to come towards L2. So because that's why in many of the normal ECGs, L2 will show the tallest positive QRS complex. So the L2 is positive, tallest positive QRS complex of all the 6 leads, normal axis 60 degrees and normal position of the heart. So L2 will be normal position of the heart. Look at the ECG. Look at this ECG here. I have the L2, which is the tallest positive QRS complex. So of all the 6 leads, L2 shows the tallest positive QRS complex, which means I have a normal axis, normal position of the heart, and it is 60 degrees. So 60 degrees is the normal position of the heart. Whereas my AVF shows the tallest positive QRS complex, it is a vertical lead, isn't it? That means I have once again a normal axis, but the number is 90 here, plus 90. And because it's a vertical lead, if AVF shows the tallest positive QRS complex, I have a vertical heart. So I have a vertical heart. So now look at this ECG. This ECG has got the AVF shows me the tallest positive QRS complex. So I have once again normal axis, 90 degrees and vertical heart. So now we can understand the normal axis range is going to be between 0 to 90, which is represented by L1, L2 and AVF. This quadrant is the normal axis quadrant. So any one of these 3 leads show the tallest positive QRS complex, you are dealing with the normal axis. In normal axis, you must know whether it's the horizontal heart, normal position of the heart, or the vertical heart. Right. Now we come to the abnormal. If L3 shows the tallest positive QRS complex, I am dealing with a right axis deviation, isn't it? L3 is the right sided lead. So right axis deviation, the number is beyond 90, which is abnormal. Beyond plus 90 is abnormal, is plus 120. And the commonest cause of right axis deviation is right ventricular hypertrophy. In any right axis, you have to look for right ventricular hypertrophy. How to look for right ventricular hypertrophy? I told you tall R wave in V1. So that is a right ventricular hypertrophy. So here, the 3 points about L2, L3 are, whenever L3 shows the tallest positive QRS complex, I have a right axis plus 120. I have to look for right ventricular hypertrophy, which is a commonest cause. The next cause is left posterior fascicular block. I told you about 2 fascicles. The left posterior fascicular block also can have right axis, but the commonest cause is right axis deviation, is right ventricular hypertrophy. If my AVL shows, look at this electrocardiogram. So once again, you can see in all the 6 limb leads, my L3 shows the tallest positive QRS complex. What are the 3 points? Right axis plus 120, right ventricular hypertrophy, or left posterior fascicular block, which is if there is no RVH, then you can consider left posterior fascicular block as the cause of right axis deviation. Now we go to the opposite, superior lead. The superior lead is AVL. Because it's superior lead, my number is minus 90. So AVL shows the tallest positive QRS complex is abnormal axis. What axis? Left axis. Number is minus 30. Commonest cause of left axis is left anterior fascicular block, and followed by left ventricular hypertrophy. Commonest cause is left anterior fascicular block, followed by left ventricular hypertrophy. So 3 points about AVL being the tallest. So look at this ECG. The AVL is the tallest QRS complex of all the 6 leads. So what are the 3 points about AVL being the tallest QRS? It is the left axis, minus 30. Left ventricular block is the commonest cause and left ventricular hypertrophy. Between right axis and left axis, what is the difference? In right axis, you put hypertrophy first and vesicular block next. Whereas in left axis, you put vesicular block first and then ventricular hypertrophy next. So this is the 2 clinical implications of right axis and left axis. Then, of course, if the AVR shows the tallest positive QRS complex, I have a northwest axis. So look at here, my AVR is showing the tallest positive QRS complex. None of my 5 leads are showing the tallest positive QRS complex. So the 3 conditions I have to suspect whenever the AVR shows the tallest positive QRS complex is severe COPD, complex congenital heart disease, or skeletal abnormalities where the heart gets rotated and the axis goes from inferior to superior and to the right. So 3 conditions are congenital heart disease, skeletal abnormalities, and COPD. Now, this is the 4-quadrant animation. So whenever the quadrant is the left and inferior quadrant, this is a normal quadrant, 0 to 90, L1, L2 or AVF being the tallest normal axis. And left and right quadrant is the right axis deviation, L3 being the tallest, 120 degrees is the right axis. Left and right quadrant is right axis. Left and superior quadrant is left axis, where the AVL is there, left axis deviation. And right and superior quadrant is grossly abnormal axis, where there is AVR, northwest axis. So normal axis, right axis, left axis, and the northwest axis or the 4 axis. So normal axis, make sure whether it is a horizontal heart or a vertical heart. Horizontal heart, L1 is the tallest. Vertical heart, AVF is the tallest. Horizontal heart can happen in obesity and pregnancy, and vertical heart can happen in emphysema. If the right axis deviation, commonest cause is right ventricular hypertrophy, look for conditions like pulmonary stenosis, pulmonary embolism, or the cor pulmonale, or atrial septal defect, congenital heart disease producing right ventricular hypertrophy. Commonest cause of right axis is right ventricular hypertrophy. And if you exclude right ventricular hypertrophy and have a peculiar initial and terminal vectors, you can diagnose left posterior vesicular block. Except in neonates, in all ages, right axis is abnormal. Whereas left axis deviation, the commonest cause is left ventricular block, AVL being the tallest, and the left ventricular block. Left ventricular hypertrophy also can cause the left axis deviation. In elderly, left axis deviation can be accepted because of the aging, but in young age, left axis deviation is abnormal. So this is my final slide and final summary of the axis. So whenever you want to look at the where your ventricular depolarization is traveling, in which direction ventricular depolarization is traveling, look at first the L1, L2, and AVF, which represents the normal quadrants. Any one of these 3 leads showing the tallest positive QRS complex, where the AVR is going to show the negative QRS complex, you are dealing with a normal axis. So if the L1 shows the tallest positive QRS complex, it is normal axis, 0 degrees and horizontal heart. If the L2 shows the tallest positive QRS complex, you are seeing a normal axis, 60 degrees and intermediate heart. And AVF shows the tallest positive QRS complex, so it's once again normal axis, 90 degrees and vertical heart. If these 3 leads are not showing the tallest positive QRS complex, look at the L3 and the AVL. If the L3 shows the tallest positive QRS complex, you are dealing with the right axis, plus 120, right ventricular hypertrophy, and the left posterior vesicular block. If the AVL shows the tallest positive QRS complex, it is a left axis, minus 30, left ventricular block, and LVH. If AVR shows the tallest positive QRS complex, it is northwest axis, congenital heart disease, skeletal abnormalities, and COPD. So this is how you can actually look at the individual leads and determine the axis and also the number within a minute actually. So within a minute, what you have to see is just 6 leads, which lead has got the tallest positive QRS complex and what its implications are. When you look them like this, so except in neonate, right axis is abnormal and left axis may be common in elderly. So this is what the clinical implication is. I hope you are all experts today in the understanding of electrical axis. And before we end, we give you the 10 commandments of ECG reading. So always interrupt ECG with the clinical history and findings, and always look at the patient's age, sex, and also the clinical presentation. And look at the standardization. I told you vertical bar of 10 small squares and the speed of 25 millimeters per second. look at whether the leads are, the electrodes are correctly placed and the leads are correctly recorded. So please remember the normal variants. I told you some of the normal variants like low voltage T wave. Always compare with the old ECGs before you come to any conclusion, and look for inobvious things rather than obvious things. And also check additional leads, especially the right side leads in, I told you, series situations, and also the posterior leads. And whenever you take serial ECG in ICU, mark the chest leads position for the first ECG and take every day in the same place the serial ECGs. If you take serial ECG in different places in the chest leads, chest electrodes, you cannot compare the ECGs. Common things are always common. And beware of non-cardiac impulse. I told you many non-cardiac impulse like electrolytes, skeletal abnormalities, COPD can also produce a lot of ECG abnormalities. So although I told you in 2 hours, very, very difficult ECG with a very rapid 4 lectures, and I can just tell you that if at all I have succeeded in eliminating the fear of seeing ECG, I'm happy. I may not be teaching the full ECG in 2 hours, cannot teach that. But in these 2 hours, if you are able to see, I'm confident enough to see and take the ECG and see something I know about the ECG, I will be happy. The ECG is definitely difficult because I told you it's a very peculiar investigation where the same change can represent many, many abnormalities. For example, we have 108 causes of T wave inversion. The same T wave inversion can have 108 etiologies. That's why the same change does not represent a single disease. That's why the ECG is difficult. But it is also interesting because it is difficult. It is not fun to master something which is very easy. It is a very satisfying feeling, and it is also great fun when you master something which is very difficult, that is electrocardiogram. And it is the most cost-effective investigation in the world, where the patient pays 200 or 250 rupees. The amount of information you get is enormous. The amount of diagnosis you make, the amount of practical decision you are going to make, and the amount of lives saved because of electrocardiogram is so huge. For that, we have to pay tribute to our Willem Einthoven, who got us this wonderful cost-effective investigation and has cost more than 100 years, but still strong and going. Thank you for your patient listening.
Hari?
Sir, thank you so much, sir, for that wonderful lectures. And if there are any queries, you can post it in the chat box so that sir can answer 1 or 2 queries.
No, it's always a pleasure hearing Chenni sir giving us knowledge about ECG again and again. Thank you, sir. Thank you very much, sir.
Thank you, sir. Thank you, sir.
Sir, you make it so simple and so inspiring that even for, I can see a few surgeons also who have joined today in the learning. So thank you so much, sir. And I request all the participants to register for GCDC 2025 by logging on to gcdc.org.in, and you can register today to hear more lectures. Unfortunately, we'll be missing sir there, but I think we'll hear in another lecture as well. Any queries?
Somebody was talking with Vijay Kumar that chat box and everything about Chenni sir. Chenni sir said that whatever Hari has written, whatever the prelude was given, was too high about him. Chenni sir, it's not Hari's alone. It was AI that was trying to give about you, sir.
Yes.
Sir, அதாவது சார் நாங்க உங்க கிளாஸ்ன்னு சொன்னோடனே ஒரு 750 பேர் சேர்ந்திருக்கிறாங்க இப்ப இந்த குரூப்ல. So, I mean, any number of classes we organize, it's a tribute to your teaching, sir. I think you have been doing it for years, and it's wonderful hearing you again and again and again.
There is one question
Whatever
called
we told about you is not Hari's or Ravi's. It is AI's, sir.
Yes, sir. Yes,
Not
sir.
so, sir. Not
I
so,
also
sir.
applaud the same, sir. Dr. Pichumani here, sir. I also applaud the same.
Just
Fantastic. Thank you very much for all the education that you've been imparting for the past so many years to all of us, sir. Thank you, sir.
Thank you, sir.
To propose the vote of thanks, I request Dr. Aarti Kannan to give the official vote of thanks.
A warm good evening to all. On behalf of the Organizing and Scientific Committee of GCDC 2025, we take immense pleasure to thank first our Chief Patron and Guru, the backbone of the event, Dr. Arulraj Sir, for his thought-provoking talk. We would also like to thank Professor Dr. Chenniappan Sir for his mesmerizing and elegant talk on basics of ECG. We had a grand scientific feast today. We thank Dr. Pichumani Sir and Ravi Shankar Sir for their welcome note. I would like to also thank the organizing secretary of the event, Dr. Hariharan Sir, for his ever-energetic and excellent arrangements and coordination. We also thank all the delegates for their active participation, without whom the event would not have been a success. Let's all meet again in GCDC pre-conference series soon with more interesting clinical topics in cardiodiabetes. Thank you, one and all.
Thank you, sir. Thank you, sir.
Chenni sir, there's one small doubt that they have posted. Why is repolarization from epicardium to endocardium causing a positive T wave? Please explain.
So it's a very good question. So, for example, if something is depolarizing, the depolarization starts from the endocardium to epicardium, and also you expect the repolarization to start from the area which has depolarized the first. But the problem is, you must understand, during depolarization, the ventricle is getting contraction. There, the epicardium is squeezed. So that's why during systole, what happens is when the depolarization reaches the epicardium, that is where the repolarization cannot start from there, which is already getting squeezed. So the repolarization starts from an area which is, let's see, at the epicardium. That's why the repolarization starts from epicardium to endocardium. Because during that portion, the endocardium is squeezed during in systole. It is in a very stressful situation. The repolarization doesn't want to start in a stressful area. It starts from less stressful area at the epicardium, and it travels from epicardium to endocardium. So that's why the T wave is normally you expect the T wave to be opposite, because there are two opposite electrical processes. One is making inside negative, another is making inside positive. So you expect if the depolarization goes to the positive wave, you expect the repolarization to be opposite. But the problem is the both opposite processes are occurring in opposite directions. So here two negatives make a positive. That's why the T wave is positive.
So thank you, sir. There are no more questions in the chat box. Sir, thank you, sir, for that elaborative talk, and we'll meet in another class if it is possible by you, sir.
Thank you, Dr.
Thank you very much, sir.
Hari,
Thank you, sir.
Rathi.
Thank you, sir.
Thank you very much. Good night.
Thank you.
Thanks a lot, sir. Good night, sir.